A child can be surrounded by noise, friends, and constant activity, yet remain completely isolated in their own mind. In 2021, as many as 20% of children in the United States between the ages of 12 and 17 experienced a major depressive episode. Despite happening to 1 in 5 teenagers, childhood depression frequently goes unnoticed by the adults closest to them. The gap in recognition happens because we expect a child's symptoms to mirror our own. This side-by-side comparison table, titled The Expectation Gap, shows the disconnect. We anticipate adult symptoms, persistent sadness, constant crying, or visible lethargy. In children, it manifests differently: sudden irritability, abandoning favorite hobbies, unexplained stomach aches, or acting out in school. This creates a difficult trap for caregivers. You are constantly anxious about either underreacting to a genuine medical condition or overreacting to the mood swings that naturally come with growing up. If a depressive episode goes untreated, changes in behavior and thinking can last for months, disrupting school and academics, damaging their personal friendships, and their daily life functioning. To evaluate what your child is actually experiencing, look for specific, uncharacteristic behavioral shifts. If a teenager is a dedicated Minecrafter and they suddenly stop playing without replacing it with a new interest, that is a diagnostic signal. This chart plots impairment against duration. The upper right is the danger zone, where severe impairment lasts over 2 weeks, signaling potential depression. Contrast this with typical mood swings in the lower left, which fluctuate for days but quickly return to a healthy baseline. The problem occurs when a child is stuck in the danger zone, but adults misread the severity of the symptoms. A depressed child's deep irritability, frequent headaches, and plummeting grades are rarely met with medical concern. Instead, teachers and parents almost always label them as discipline problems. School psychologists note a massive cultural disparity here. While irritability in a white teenager is often recognized as depression, the exact same behavior in Black and Latinx children is disproportionately labeled as disruptive. The trade-off for this misperception is severe. When adults respond to a depressive episode with punishment or detention, they validate the child's feeling of hopelessness and leave the underlying brain disorder untreated. Effective evaluation requires prioritizing the medical data of the symptoms over assumptions about a child's character or behavior. So what pushes a child's behavior into that clinical danger zone to begin with? Caregivers often carry immense guilt, believing that providing a good home should mathematically prevent depression. It doesn't. External environmental triggers routinely override a stable household. Peer bullying, navigating a dramatic change in housing, or exposure to family trauma can rapidly alter a child's brain chemistry. Beyond external events, psychology points to specific relational predictors, most notably insecure attachment. This diagram illustrates insecure attachment. It occurs when the bond between a caregiver and a child is characterized by anxiety and uncertainty, often stemming from caregivers who are emotionally distant, highly anxious themselves, or absent. A frayed connection deprives the child of a secure emotional foundation. Without that safety net, they are highly vulnerable to depressive episodes when external stress hits. Treating a child's depression requires a mutual effort. Caregivers must be willing to humbly examine and optimize their own behaviors and family dynamics to rebuild that secure base. Once you identify the risk factors, you have to decide how to intervene. The first line of defense is establishing specific emotional habits at home. Clinical psychologists recommend a daily routine where the whole family shares 3 good things that happen that day. Crucially, the caregiver must use this time to highlight one positive trait they appreciate about the child. This normalizes talking about emotions without feeling like an intense interrogation. However, it requires relentless daily patience, and for severe clinical episodes, home habits alone will not be enough. If the symptoms are entrenched, clinical intervention becomes necessary, most commonly through cognitive behavioral therapy, or CBT. Because depression involves structural changes to the brain's function, CBT, sometimes supported by antidepressant medication, directly addresses those changes. It equips the child with proven mechanisms to process negative thoughts. The clinical route demands a high investment. Caregivers must spend time finding the right therapist, navigate insurance costs, and commit to the process for at least a month before expecting to see tangible shifts in behavior. At-home habits foster emotional safety, but clinical intervention is often necessary to directly address the biological symptoms of the disorder. To choose the right path forward, we can map these options against your child's specific situation. This decision tree begins with the most important diagnostic question. Has the negative change in their behavior lasted for more than 2 consecutive weeks? If the answer is no, utilize the wait and support strategy. Implement low-pressure family bonding activities, like the 3 good things habit, and give the phase time to pass naturally. If the answer is yes, you need to check for clinical volume. Are 5 or more depressive symptoms present during that 2-week window, like extreme irritability, feelings of worthlessness, or severe sleep changes? There is one critical override here. If there is any sign of suicidal ideation, all wait-and-see strategies stop immediately. You must seek immediate crisis intervention by calling or texting 988. If 5 or more symptoms are present without an immediate crisis, the definitive next step is to get a formal assessment from a qualified psychologist or psychiatrist. Diagnosis depends on the duration of these behavioral shifts and the specific ways they interfere with a child's normal life. A professional assessment identifies the exact nature of the problem, ensuring that a treatable condition does not continue without help.